Hello everybody, sorry I couldn't be there today, I'm not feeling that great. My voice is gone, so hopefully I can make it through this. So this is embryology, it's week 6, it's Wednesday, summer 2025. Off we go. Where have we been? So we built a neural tube is where we've been. Remember how that started? We took the ectoderm and we released some biomolecules which morphed these cells in the center, kind of toward the cranial region, into a new cell type called neuroectoderm cells. Great. Then what we had to do, so we built this part first, and then the next step, which is going to be the brain, the next step is to make this long, which will be the spinal cord. So we went through how to do that. And then, once it was made, we took the flat plate and we turned this median hinge point region into triangular shaped cells. And that kind of gave us this flying V-like structure. And this is a head-on view. Amnion would be up here, and secondary yolk sac would be down here in each one of these. And you can see how we created a hinge here, and we created a lateral hinge point, and these deepen to the point we get kind of a tube-like structure toward the end. It was also really important we talked about these green cells. Those are neural crest cells, which will become almost all the nerves in the body, at least part of those nerves. So we said those have to delaminate and escape. We don't want them to get trapped inside the neural tube. That would be bad. I think that's about where we left off. Yep, everything we said. Got to get those neural crest cells out of there. So what happens if some of them do get trapped? So in this little cartoon here, I kind of photoshopped in some trapped ones. And that forms a condition called a spinal dermoid or a spinal epidermoid cyst. So spinal dermoid cyst or spinal epidermoid cyst. And that happens because these cells didn't get the heck out of there. They got caught. These neural crest cells got caught in there. And here's an MRI. There's a T1 weighted image. There's a T2 weighted image. And you can see a big old giant tumor that's inside the spinal cord itself. And that is a spinal dermoid or a spinal epidermoid cyst. And we won't get into the difference between them. You might get into that in radiology further on down the road. But for me, I'm happy if you know those two. Spinal dermoid cysts, spinal epidermoid cysts occur because of this, because neural crest cells got trapped in the neural tube. And when you look at that thing, can you imagine the tracks, all the spinal cord tracks running in there? And the spinal cord is smashed in there. So you get all kinds of upper motor neuron lesion signs downstream from where this happens. These are considered congenital, of course. They're not cancerous. And yeah, you can get myelopathy. Myelopathy is any injury or disorder that results in spinal cord damage and dysfunction. So myelopathy will give rise to 99% of the time or 95% of the time upper motor neuron lesions, including spasticity, neurogenic bladder. And we'll look at spinal dysraphism here in a minute, but they are associated with spinal dysraphism. Okay, some of the signs and symptoms of these cysts. Back pain could bring them into your office. Radicular pain, pain radiating down the legs. If it's a lumbar problem, pain radiating down the upper arms. If it's a cervical problem, pain radiating around the rib cage if it's a thoracic problem. And you'll have sensory and motor deficit and weakening. But the big thing is, most of the time, you'll have signs of upper motor neuron lesion, positive Babinski's, positive Hoffman's, depending on where this is. Spastic paralysis, weakness. Remember spasticity. That is defined as a velocity-dependent rigidity of a muscle that occurs when it's stretched. If you stretch the muscle, I think in class I used the example of if you extended the elbow, we're focusing on the bicep, nothing would happen. But if you extended the elbow really fast by grabbing the forearm, it would catch and it would be really rigid. That's classic spasticity, and that's one of the number one signs of myelopathy. Treatment, of course, if it gets to the point where you're in a wheelchair and you can't walk, you might consider trying spinal surgery to remove it. According to the research, 90% shows at least some clinical improvement. Dysfunctional bowel and bladder doesn't do so good, though. Remember, that S3 nerve has 3 or 4 days to get the pressure off it, or it's pretty much damaged. One of the big problems, though, they like to grow back. They have a 25% recurrent rate. All right, so there's that little rabbit hole. Let's get back to our neural tube. So we said the neural tube starts closing in the middle, and it kind of zips up toward the cranial end and zips up toward the caudal end until it's completely zipped up. Pretty soon you have these little holes right here that are formed. Those are called neural pores. So the one toward the head is called the cranial, or sometimes I've heard it called the anterior neural pore. The one toward the back end is called the caudal neural pore. Okay, so closure, you should have an idea of when these things close and which one closes first. So, because once these neural pores completely close, because these will close way up here, completely seal off normally, then the process of neurulation is over and you have a primitive CNS, central nervous system, is basically born. And once the neural tube is mature and done and closed, the neural pores are closed, you could say, just like with the definitive nodal cord, you can have a definitive neural tube. And that means it's all done. So the cranial neural pore closes day 25. The caudal one closes day 28. I think there's a question floating around the test bank about making, at least one of the answer choices is to see if you know which one closes last. And it's the caudal neural pore that closes last. We won't worry about these somites yet. We'll talk about them later. So by the end of week 4, we have a definitive neural tube, and our central nervous system is born. It's basically a tube with kind of a thick part at the front and a narrow part at the back. And there's a whole bunch of problems happen if this neural tube doesn't close up. Maybe a chunk of it, a couple somites worth, like this part never fuses and it's left open. So we need to talk about that. And those are called neural tube defects. Neural tube defects. All right, so neural tube defects, one of the most common problems with neurulation is a chunk of this fails to close. In this cartoon, you can see this one is sealed right up. This one's got a big old space in it right there, and that creates a neural tube defect. And let me warn you right here about the classification system from neural tube defects is all over the place. It's a gigantic mess. Very hard to get the story down. Radiologists use a different system, a classification system for these neural tube defects. Embryologists like Moore use a different one. Carlson, another embryologist, uses a different one. So it's kind of a mess, but I think I have a pretty good presentation that can get you through anything. But we're keeping an eye on Moore's because that's our chiropractic board book. Those are the board questions come from that. So yeah, one of the most common problems with neurulation is the tube doesn't fuse shut. And it creates a hole right there because of a failure to close. We haven't got to this yet, but the neural tube will become surrounded by bone. We have this stuff called paraxial mesoderm that will encircle the neural tube and make our bone, our vertebral arch, our pedicles, our vertebral body, everything. And so if this doesn't close, in some cases, your posterior arch doesn't close, like your spinous process never turns to bone. Or maybe it doesn't even form, or one of your lamina. Or maybe both your lamina and your spinous process don't form. So those are neural tube defects that do that. And there's two giant kind of grandfather and grandmother classifications. There are spinal dysraphism and there's cranial dysraphism. We're not going to focus on the brain and the skull as much. Spine is our domain, so we're really going to focus on this. And spinal dysraphisms, and confusing right off the bat, some authors use spina bifida as an AKA for this giant top of the board classification system, which is terrible. But spinal dysraphism, you can have open spinal dysraphisms or you can have closed spinal dysraphism. Okay, and we'll expand on that. Same with cranial dysraphism. Dysraphism means that the skull didn't form. And you can have an open one where the brain is like sticking out, or a closed one where the skin is covering the brain. And we'll explain that as we kind of go through this. So again, spinal dysraphisms, we're focused on that. So we have closed spinal dysraphisms. So that means there's a defect in the posterior arch. When I say posterior arch, we're talking about usually where the lamina meets the spinous process. But the key with a closed spinal dysraphism is that the muscle, or at least the skin, is still intact. So even if some of your cauda equina is herniating out through the defect, it's going to be covered by skin. If it's covered by real skin, not cheap paper thin kind of scarred up skin, but real skin, you have a closed spinal dysraphism. An example would be spina bifida occulta. That's not the only example, though. We can have meningeal seal, can be closed spinal dysraphism if the skin is intact. The key is the skin. The skin is the skin covering, normal skin covering the defect. On the other side of the coin, more serious ones, we have open spinal dysraphisms. So spinal bifida aparta, oh, it's confusing. Spinal bifida cystica. These are really, and spinal bifida manifesta, that's a really old term. I don't think it's around anymore, but these are 3 AKAs. They're not really AKAs for open spinal dysraphism. This is the main top of the board category, and this is a subcategory underneath it, is the way to think about that. They're not really AKAs. And yeah, this means that the neural tissue and or the meninges, so the spinal cord or the roots of the cauda equina, the traversing roots, they went out the defect, and they're on the outside. And there's no bone, there's no muscle, there's no real skin over the top of it. That's an open spinal dysraphism. And again, skin, sometimes it can be covered with a very thin membrane, but it's not true skin. That if it's not true skin, it's still an open spinal dysraphism. Got it? Yep, it's one of the most common congenital anomalies in the human, so it's very common, especially little spina bifida occultas. We see those all the time. Severity can range great from spina bifida occulta, which is a closed spinal dysraphism, to a life-threatening spinal bifida aparta, where your spinal cord is sticking out with no skin over it. So, huge range of these things. What can cause these things or increase the risk? Well, the teratogens, of course. If you get exposed in the 3rd week of pregnancy, alcohol, cigarette smoke, certain drugs, especially cocaine, herpes simplex, x-ray exposure, folic acid deficiency, it can all increase the chance of getting one of these dysraphisms going on here. Parental screening is a must. If you're going to have a kid, you can get this done. And they look, it's a blood test where they look for a protein called alpha-fetoprotein. And normally it's got a certain value. But if it's really high, that's a strong indication that you have some type of dysraphism going on, whether it be spinal or cranial. That's a red flag. On the other side of the coin, if it's really low, it could indicate chromosome abnormalities like Down syndrome. See how that works. Spina bifida occulta. So what is that? We're going to run into that all the time, right? This is a subtype of closed spinal dysraphism. So that's not as dangerous. That means it has at least skin over the top and maybe more. In effect, spina bifida occulta, you have skin and muscle and all your ligaments. Everything's fine except you got a little gap, usually where the lamina meets the spinous process, like this little space right there. That's the spina bifida occulta. No big deal. You can adjust those. There's no contraindications of any kind to those in most clinics. Of course, check with your clinic because everybody's clinic is different, but it's pretty strong, so you're not going to have trouble with that. I can't remember. I don't think in Palmer we could still adjust those things. I'm not sure how Life is, but I assume it's the same. So yeah, so there you go. It's a closed spinal dysraphism, so there's nothing sticking out. Great. Oh, just a little, I guess I could have put this on a little earlier. Here's an overhead view of a lumbar vertebrae. Remember, this is the spinous process sticking right back. This is the lamina. The two lamina kind of form the spinous process there. So when I say posterior arch, we're really talking about the lamina spinous process. Technically, you have an articular pillar here and a pedicle. So the entire posterior arch is this whole thing here. But with spina bifida, you get a little slit right here where it doesn't turn to bone. Okay. Still on spinal bifida occulta, incidental finding. There's no pathology associated with it. It's just kind of an incidental finding. But that said, if you see one, you do have to watch out for other congenital anomalies, like transitional segment, atrial septal defect, ventricular septal defect, horseshoe kidney, because that does increase the chance. If one thing is messed up, you always look for other things that are messed up. But again, epidural structures, dural sac, spinal cord, they're all where they're supposed to be. They haven't herniated out. So, great. Can you see the spina bifida occulta in this picture? Of course you can. It's right there. You can see that little dark line. And the spinous process has a weak spot in it. But that's it. Your cauda is still in the right place. The thecal sac hasn't moved out of there. Great. Quiz. 43-year-old female comes to your office with chronic, 7 months worth anyway, of low back pain. It's rated 3-4 on a 10 scale, numeric rating scale. You can call that a visual analog scale if you want. Can go higher if she overdoes it. She injured her back lifting a heavy couch and spring cleaning. So it's been going on a while. Neurological exam is normal. Chiropractic exam finds some fixations, I guess you could call those subluxations, some stuck facet joints in the lumbosacral junction with tenderness, some muscle spasm as well. You do Kemp's test, which is positive. What's Kemp's test for? That's for facets. It jams the facets. And so you're thinking facet here, which makes sense because you got a fixation. You got a facet, a hot facet here. She has no trouble sitting. She does have trouble standing. That again is facet. Sitting is disc. Standing is facet. And she's never had an x-ray. It's been quite a while, so you definitely want 7 months, for goodness sakes. If it goes more than 3 or 4 months, or 3 or 4 weeks, you should get an x-ray if the pain hasn't went away. So here's the patient. What do you think? We can blow up that area right there. You can pause the video. Yeah, we see spina bifida occulta right here. It's just a little gap. Great. The exam showed no sac protruding from her skin or anything like that. So, yeah, so it's incidental. But remember the rule. If there's one thing wrong, there's could be something else that's malformed. And some of you immediately see it, but where's the L5 transverse processes? There's L4, transverse process right there. Where's L5? It's spatulated. It's that gigantic thing right there. So this is a transitional segment. 1, 2, 3, 4, 5. This is happening at L5. So it's got a spina bifida. and it's got spatulated spinous transverse processes. I don't see a neoarthrosis. Sometimes these make a joint with the sacroala. So that's just, what is that? That's just sacralization of L5. Great. Yep. You see one abnormality, look for another. Great. There's the answer right down there. So diagnosis is facet fixation, or facet syndrome with fixation, or you can say subluxation if you want. L4, L5, L5S1, complicated by sacralization, complete sacralization, L5S1, without evidence for neoarthrosis. You always want to say neoarthrosis because sometimes it forms a new joint, and those can definitely cause chronic pain. So, great. IUD in there as well. There was an intrauterine device. See it there? You caught that, right? Great. Just another look at it. Maybe facet tropism in this one. There's a slit right there, so that's pretty sagittal. It's supposed to be coronal here. Here's a sacrum with the same thing. Oops. You can see that. Great. All right. Here is a cartoon of this. So this is spina bifida occulta. Again, this is under the heading closed spinal dysraphism. And we can see in this one, it's definitely a thoracic spine, but we see spinous process has not failed. And there's the skin. It's intact, but it's kind of hairy down there. It's got that frond tail, right? You've heard of that before. Don't ever adjust anybody over a frond tail, because in this patient, probably wouldn't adjust this patient if there's no spinous process there. But this is a closed spinal dysraphism, spinal bifida occulta. The skin is intact. There's nothing herniating out. There's no kind of ball of stuff out here. Make sure you know what this frond tail is. It can get, this is like a really crazy one. Usually it's just a little patch. But they do indicate structural problems underneath. So again, don't go doing a grade 5 mobilization here until you get an x-ray and see what's going on there. Another one is a sacral dimple. There's a picture of it. Sometimes they have a nevus flammeus, kind of like a port wine stain over here. One of my daughters has that. She's got a spondylolisthesis. So those are all warning signs. So don't be careful with those people if they have those warning signs. Yeah, don't adjust until you get an x-ray, because there could be a structural problem. Just another look at the sacral dimple. Great. Now let's get to the more severe ones. So next one is an open spinal dysraphism. And we have, this is really a subcategory of open spinal dysraphism. So spina bifida cystica. Some books call that spinal bifida aparta. So it's a very strong AKA, spinal bifida aparta, spinal bifida cystica. Spinal bifida manifesta, that's a really old term. I used to use that way back in the day. But these are like the word aparta. It means there's like a ball or something on the outside. Or cystica means there's a cyst on the outside. So technically these are subcategories of an open spinal dysraphism, meaning that the skin is open. That's what it means. Open means the skin is open and you can see dura mater, hopefully, maybe spinal cord material on the outside. So let's look at these. And yeah, categorization system is a mess here. So there's two subcategories. We have a meningeal seal and a meningeal myelocele. Now again, you can have a meningeal seal with skin. If you have a meningeal seal with skin covering it, then it's not a spina bifida cystica. It's just a closed spinal dysraphism. This is where it gets complicated, but almost always you're not going to have skin. And you can have skin, but if it's really paper thin and scarred, that doesn't count. So if it's like kind of mutated skin, then it does count as in this category, spina bifida cystica, strong aka spina bifida parta. Where do these live? These are types of open spinal dysraphisms. Great. Means the meninges or the spinal cord or cauda equina, depending on where you are, has actually herniated through the bony defect, and it's even went further. It's actually went through the ligaments, through the muscle, and right through the skin, and you can see this naked thing on the outside. Okay, that's a spina bifida cystica. Okay, group of neural tube defects is definition, which results in severe failure of vertebral arch to close, including muscles, ligaments, and the skin may or may not. But way more severe problem. If your spinal cord is up in this little ball, is that a good thing? No, all those tracts are going to get crushed and inflamed, and you're going to get stretch injuries or traction injuries, so not good. So another definition allows varying degrees of neural tissue to herniate through the defect. Prevalence is twice as popular as Marfan syndrome, but still rare, 0.02. There's three main types of spina bifida cysticas, or spina bifida parta, strong aka. We have meningeal meningomyelocele, and rachis, also known as myeloschiskis. So let's check these things out. So meningeal, what's that? So here's a perfect picture of it. So it's a missing spinous process here. So, and this time we can see a sac or a cyst on the outside. So it's definitely a cystica thing. And if you look at the skin, it stops. Maybe there's some little thin skin there. So this is definitely an open spinal dysraphism. And because the thecal sac is outside, but the cauda equina is still on the inside, this means meninges have sealed. The meninges have went out into this little ball. So this is a meningeal seal, and this is all dura mater. If you follow the dura mater here, you can see the dura mater lines this little cyst. But all the neural tissue is inside, so that's a meningeal seal. They're almost always open spinal dysraphisms, but once in a blue moon you can have full skin over the top. If there's full skin over the top, then it's classified as a closed spinal dysraphism. It doesn't happen very often, so a lot of people, instructors, forget to warn you about that. So, yep. So may or may not be covered with skin and muscle. If it's covered with skin, then it's a closed spinal dysraphism. If it's not, which is probably 90-95% of the time, not covered by a real skin or any skin, then it's classified as an open spinal dysraphism. And AKAs for that, some authors say these are subcategories of open spinal dysraphism, but spinal bifida parta, spinal bifida cystica. Some authors say these are AKAs for one another. So it gets very confusing. Boards have to be very careful when asking questions about these. Yeah, in either case, the meninges, so the dural sac, in other words, that's made of what? What's the dural sac made of? Obviously dura, and arachnoid is stuck to the bottom of it. What about pia mater? Pia mater's here. So yeah, that's the story there. Key point, traversing nerve roots are not herniated through this. Got it? Okay, let's look at this one. Does this one have skin? It's definitely got a cyst. So you want to call it spina bifida cystica, but technically it's not, because it has skin covering it. So it's really just called a closed spinal dysraphism. And the subcategory would still be meningomyelocele. So meningomyelocele can be open spinal dysraphism, which it usually is, but it could be a closed spinal dysraphism. It depends about the skin and the cover of this thing. It's not the next level, because the dura and the neural tissue is still inside, so it's just the meninges are outside, so it's a meningeal seal. Got it? Now, I feel like I have to cough, and there's no way to mute this, so I'm struggling here. Meningeal myelocele, so the meninges are out. Myelo means spine, neural tissue. Seal means herniated. So meningeal myelocele means that not only is the dura on the outside, but in the lumbar spine here, we can see the cauda equina is also wandered out here as well. This is very serious because these nerves get trapped, they get pinched, they get stretched, and you're going to have problems with your lower extremities. So, and is it closed? Well, there's the yellow skin. No. See how the skin doesn't close it? There's like a rudimentary kind of thin fibrous tissue here. So this is definitely a closed spinal dysraphism. Specifically, this is a class of spina bifida cystica, aka spina bifida aparta, I should have put there, which is a subclass of open spinal dysraphism. Did I say closed a minute ago? It's open. It's definitely open. Got it? Yeah, occurs when the thecal sac, cauda equina have herniated through the neural arch defect and herniated right out through the muscle, ligaments, bone, and skin. There's nothing there except maybe a little kind of makeshift fake skin. So much greater chance of having trouble. In fact, the 16-year survival rate from these kids is 85. You lose 15% of them, probably from surgery and complications from surgery. Here's another look. So what is this one? Well, we have, let's look at the dura. Here's the thecal sac in pink. It's definitely on the outside. There's no posterior arch at all in this one. So it's definitely on the outside. And what's the skin doing? The skin is dead right here. There's like a thin scar tissue right here. So this one's meningeal myelocele under the category of spina bifida aparta, aka spina bifida cystica, which is under the category of open spinal dysraphism. I know, confusing, but that's the way it is. Remember the gastritis in GI. Wow, what a mess that was, the way they classify those. Here's a couple here. So there's a meningeal seal without real skin. So that's spina bifida aparta. Here's a meningeal seal, severe defects. Look at the feet are all thin and they're turned in. So meningeal myelocele here, this one. Now the last one is myeloscus kiss, aka rachis. Myeloscus kiss, rachis. Even more dangerous. So what's this one about? I mean, how more dangerous can we get when all this neural tissue as well as the dura is out? Well, how about if the neural tube never forms and it just stays in a flat plate? And that's what myeloscus kiss is. It is a subcategory of spina bifida cystica. There's never skin over the top. It's almost always fatal because the neural tube hasn't even formed yet. And it's a true severe neural tube defect. The neural plate hasn't even rolled up yet. It's a flat neural plate. And these kids, when they're born, I couldn't even find a picture of one. So rare. But the kids, when they're born, have a flat neural plate exposed with no skin, and there's no dura. There's just nothing there. It's just like the primitive spinal cord is just showing. So no arch, no muscle, no ligaments, no skin, no meninges, and really no spinal cord, just a flat plate. So that's what a myeloscus kiss, and these are almost always fatal. Here's a cartoon of it. So there's the spine of a baby born, and it's a flat neural plate. Now above and below this, the spinal cord will be complete. It's just at the level of this defect that this happens. Okay, so neural plate is exposed. There's no, see the dura is here. thecal sac, dural sac, and it just stops. There's nothing covering this thing at all. Okay. Now what do you call this one? Well, there's definitely a cystica of some kind. If we look at the skin, it's not covered by skin. You can see the dark brown here stops, so it's not covered by skin. So it's definitely an open spinal dysraphism. And the dura mater's out there in white. There's the thecal sac, the dural sac. That's out there. But the neural elements are out there as well. There's the members of the cauda equina. So that's a spina bifida cystica meningomyelocele. Okay, or you could say it's an open spinal dysraphism because there's no skin. The class is spinal bifida cystica, aka spinal bifida manifesta. Oh, they don't use that too much anymore. But spinal bifida parta, spinal bifida manifesta, those are the 3 AKs for that. Okay, so this one is all kinds of problems. So the cranium hasn't even formed. So no bones, and the brain is herniated out. So some of the skull has formed here. You can see the ears, but there's no skull. So that's called the cranioscuscus. Cranioscuscus. And this is called an open cranial, what is that called? Let me think of it. Is that right? That word escapes me right now. But that's a cranioscuscus. It's a cranial dysraphism. It's an open cranial. Yes, that is right. Open cranial dysraphism. What do you think of this? Well, that's a massive failure of the posterior arch in the skin and everything to form. And the question is now, so it's definitely a open spinal dysraphism. The spinal cord is definitely on the outside. I mean, we can see it, the meningomyelocele. But I wouldn't call it a rachis because it's not flat. The cord is still round, so it has went through the normal process of kind of rolling up into a tube. So great. There's just another one, cranioscuscus, failure of the brain portion of the neural tube to close, which allows in the skull portion to close, and it allows a herniation of brain. And there's some meninges are herniated there, so that's called the cranioscuscus. These are almost always fatal as well. Neural crust cells a little closer. Actually, we're stopping right there. So sorry I couldn't do this in person, but got a bug. I think it's from the grandkids. We had 10 grandkids over here on Saturday. My wife and I are both like, funny thing is none of the grandkids are sick, so who knows? They're probably carriers, but I'll survive. See you guys next week. Email me any questions. We don't have any testing next week. Next week is week 7. Week 8 is our next test. All right, see you later.